Well, good afternoon, everyone. Thank you for bearing with us. We get everybody put together this afternoon. This is Kevin McGinnis with the February edition of the Community Paramedicine Insights Forum. We are brought to you by the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research. And my partner in crime, Gary Wingrove, who heard immediately at the beginning, is our technology guru for the show, and he is coming to us from the Mayo Clinic. This afternoon, I'm very pleased to have some of my own Maine colleagues who have been working on one of 13 pilot projects for community paramedicine going on in the state of Maine and have been going on for the past 2 to 3 years. Their program is operated from Lincoln County Healthcare, a part of Maine Health, in the area of Waldoboro, Boothbay, and Damariscotta, Maine. And we're pleased this afternoon to have Julie Carroll, who works with Lincoln County Healthcare and has been the program director for this unique community paramedicine program, and Scott Lash, who's director of the Boothbay Regional Ambulance Service, joining us to discuss the program. This is a fairly unique program, as I noted in the notice that went out to folks. This is a hospital-based program with partnering with 3 individual ambulance services serving 3 different communities, and it's embedded in the home health program that is affiliated with Lincoln County Healthcare. So there's a whole lot about this program that is unique from many of the programs we've featured on Community Paramedicine Insights Forum, and I'm really anxious to hear all. Julie and Scott and Scott's colleagues at the 2 other ambulance services have been doing this program now for well over a year, near on 2, I think.
Yes.
And have met with very good success in the program. So I am just going to turn this over to Julie without further ado. Ms. Carroll?
Great. Thank you so much for allowing us to come speak here. We're really excited to talk about our program. So we are the Lincoln County Community Paramedicine Pilot Project. And today I wanted to provide an overview of the implementation of the Lincoln County Community Paramedicine Program, discuss Lincoln County and the details around our program, and then take some time to answer your questions on what I might not have addressed during the presentation. So for a little bit of the background, we're all familiar with the challenges in healthcare, and some of the most frequently cited challenges are the problems with readmission and the frequent utilizers. So this was an issue that was talked about a lot at the Maine Health System level, and that is the larger organization of Lincoln County Healthcare. We are a member of Maine Health. And what Kevin McGinnis and Matt Scholl, who's the EMS medical director, or who was at that time the EMS medical director, did was they brought eMed Health and MedStar to Maine, and they visited with Maine Health seniors leadership, and that's really where the interest in community paramedicine peaked. A lot of discussion happened after those individual services came and talked about what their program has done to address readmission rates and specific diseases that they targeted. So that's where the ideas from the program started. I used to work at Maine Health, and I helped with the EMS program there. So there was really an effort to talk about community paramedicine and how community paramedicine could fit within the Maine Health structure. There are 13, Kevin said, but here are 12 of the pilot programs in Maine, and we were actually the last ones to get in our application for the pilot program. So I just wanted to show a list of those programs. So this is Lincoln County, and I know the picture is rather small, but Lincoln County is about 700 square miles. Our population is about 35,000 people. We were the oldest county and the oldest state in the nation, but I believe we have lost that title. But we are a very old county. There's 4 large EMS services with many smaller volunteer services in the county. And what you can kind of tell from that picture of Lincoln County is we have a lot of peninsulas on this county, and it can be a rather far distance to go down the peninsulas. So it can be really challenging geographically. And I also actually bring that up on a later slide. So we began discussions on our pilot program in July of 2013, and we had a number of people present for those discussions, which really helped. We had the Chief Medical Officer of Lincoln Health, who was also working in a Maine Health role at that time as a medical director. We had myself as a program coordinator at Maine Health. We had the Executive Director of Miles and St. Andrews Home Health and Hospice. And then we had a number of service chiefs present. So a service chief present from Central Lincoln County Ambulance, Waldoboro EMS Service, Boothbay Regional Ambulance Service, who is Scott, who is also on the call. And then we had from Lincoln Medical Partners, which is our primary care physician group, we had a care transition nurse present. In our application, we set out to help people with a few chronic conditions that we were going to target. So it was diabetes, CHF, COPD, and asthma, kind of the big ones that you hear about. We were also going to look to see if we could help patients that are identified as frequent utilizers or patients that were recently discharged from the ED or hospital. And I'm not sure if you guys are aware or if this works similar in other areas, but all of our requests for service is what they call them, so the referrals to the program, they all need to be signed by a physician. So that can be a ED physician, a hospitalist, or a primary care physician, but they really need to, they all have to be signed by a physician, and we want to make sure that the primary care physician is aware of everything that's happening with the patient. So these are the major services that patients could be received or that could be requested on the referral. So phlebotomy or point of care testing, standard assessment of wounds, basic vitals and weight monitoring, physical assessments, med reconciliation, SpO2 assessment including the monitoring of O2 delivery devices, home safety and social needs assessments, and influenza vaccines. So these are all within the scope of practice of the EMS, all EMS providers, so that's what we based it on. And we looked at what chronic diseases we wanted to address, and that's how we came upon these services. So one really important thing about when eMed Health came to Maine Health that the Chief Medical Officer found really interesting was how eMed Health integrated their referrals into the home health organization that they helped with. And that was really how our program, how the referral process was organized for our service as well. So when a patient is being referred to the program, it all gets sent to home health, our home health coordinator, and then that home health coordinator looks at the referral and says, will this patient qualify for home health? So if the patient does qualify for home health, they stay with home health. If the patient does not qualify for home health, then the referral is sent on to the appropriate service. So we have 3 services involved. The home health intake nurse knows what service or what area goes with each service, so she's very familiar with that. And it's worked out really well, and I think it helped to increase the buy-in from home health. So I think there's probably only been 2 or 3 people in the course of the 2 years that we've been working on this program that have actually gone to home health. There's been a few referrals where the patient was referred from the ED or the urgent care center and they were already within home health, so the home health intake nurse noticed that, notified the physician that they were already receiving services. But it's been a really great way that our service has worked. Another really interesting thing that came out of referring patients to home health was when a patient was denied home health services, the home health intake nurse was able to start a community paramedicine referral for the patient to make sure that the patient had something in the home. So that was something that we weren't really thinking about, but that naturally occurred from the program being integrated into home health. And so then the home health intake nurse would contact the appropriate physician. So sometimes she contacted the hospitalist, sometimes she contacted the PCP and got that physician to start the request for service order. So that's been really great. The other thing that's been great working with home health is once we had started the program for a couple of months, we noticed that there was a need for patients that were being discharged from home health, so they no longer qualified for those home health services. We noticed that they needed a little extra help. So what we started to do was we started to see patients for 6 to 8 weeks after they were discharged from home health. And so that again was the home health intake nurse would get a signature on the request for service from the primary care physician, and then she would send it off to the appropriate agency. And that's been really great, and that's actually a huge area for our referrals for the program, and it's worked really well. So our actual start date was March 1st, 2014, so we've been going almost 2 years now. We have a 3-year pilot, which is what was awarded from the state for most of the 12 pilot programs. Our services involved are Waldoboro EMS, Central Lincoln County Ambulance Service, and Boothbay Regional Ambulance Service. So Waldoboro is a public service, CLC is a quasi-municipal service, and Boothbay Regional Ambulance Service is a private service. And each service has about 30 to 36 staff members on each service, and the levels vary from EMT basic to EMT paramedic. Another thing I wanted to say here was that generally when the referrals come into the service, they look at what is requested on the service, and then they pick the team working within whoever's on. And generally the referrals or the visits happen within 24 to 48 hours when they get the request for service. So they send out a team of who is on to go and see the patient. So they will call the patient and say, this is the time that we're planning to come and see you, and then go see the patient at that time. They do generally give the caveat that something could come up and we might have to cancel, but that is generally how the calls are dispatched for community paramedicine. Scott, did you have anything you wanted to add there?
No, well, I guess more of the point, we also do some internal triaging, so we make sure that the right crew mixture by license level is appropriate for the patient. So if we have someone that needs a follow-up assessment for atrial fibrillation, we'll make sure that the provider that we have that goes out is licensed to interpret that EKG. So there are times when we're able to send out a purely BLS crew that has a little more exposure to patient assessment in that setting than they would ordinarily get.
Perfect. So this was our referral map when we first started. So if we can go through it. So patients identified by PCP hospitalist or even patient request. We haven't generally had any patients request the service, but that's definitely something that they could do by calling their primary care physician and saying that they would like a community paramedic visit. So if the patient has a primary care provider, the community paramedicine request form will be filled out by a physician. We also had that the care transition nurse, so specifically Bobbi Jo, could help with that request form, and she does help generally in the office get either the physician's signature or alert them that, hey, she noticed that this patient might need a little bit more help in the home, and then start the referral that way. And then the community paramedicine request form is transmitted to home health, and then they check to see if the patient is eligible for home health. If they're not, the home health nurse, intake nurse, determines patient service area and transmits community paramedicine request form to the EMS provider. The EMS receives the community paramedicine request form. EMS assigns team by service requested. CP visits patient for the number of reasons that they could go for, and the assessment documentation paperwork is completed, and then it's faxed back to home health. so that at home health we have the request for service and the visit record completed, and then the visit record is sent to the primary care physician's office where the PCP signs off on the paperwork. So they'll initial the bottom of the paperwork, and then the paperwork is scanned into the medical record. So it's a part of the medical record that anybody that has access to Epic can see. So far for our program, we've done 652 visits. Boothbay Regional Ambulance Service has done 281, CLC has done 225, and Waldoboro has done 145. And like I was saying, our county is pretty old, and our average age of visits is 80. I think the 102 is the oldest patient that we have visited. We had two visits to patients under 18. Those both happened fairly recently, and I think there's an area where we could see more referrals coming in from that age group. We've had 17 visits to patients under 50, 98 visits to patients 50 to 69, and 532 visits to those 70 and older. So that's not unique patients. That could be the same patient multiple times. So these are just to give you an idea of the visit types that we've done. So assessments and vital signs, 181 visits, asthma 3, vital signs 79, blood draws 138, blood pressure checks 3, hypertension were 7, CHF is 116, COPD is 10, diabetes 22, wound checks were 22, flu shots we've done a few of, and they were 3, home safety or social checks are 32, med compliance is 4, and then we had an area for other, and there was 2 cardiac rhythm strips. So we've been lucky with our pilot program that we've been able to identify some funding to help with our pilot. So we first received a $1,000 donation for community paramedicine after we spoke at our local board meeting. And I've come to find out that it's actually somebody that helps with the program that was a little frustrated that there weren't any funding to help the program get any of our basic needs. So that's what we use for our printing materials and marketing and other supplies that the services might need. BRAS received $40,000 to help purchase a community paramedicine vehicle. And then our development director was able to write a few grants to help get some additional funding. So we received $25,000 from the Davis Foundation and $15,000 from the Byrne Foundation that Lynn Cole was able to help us get. And that has gone mostly to the services. We're giving the services $21 per visit, which might not be enough to cover the actual visit, but it's something that we can try to help with. We have a local Miles League and San Andrews Auxiliary who we've gone to speak to, and they gave $2,500 per service, which has been great, so that the services have a little leeway with that money to use in other ways. So a lot of the money, we've given some for trainings for the services and some wear and tear on vehicles. So that's been really helpful. And then Scott was going to give a couple examples of a case study.
Sure. Thank you, Julie. One of probably the most dramatic cases that we've had was we had an elderly patient in our community that was in her late 90s and has her daughter as her primary care provider. And it was her care plan and the nature of her illnesses really required a lot of hospital admissions. We were finding that we were going to her house on 911 calls multiple times a week, and it wasn't because of really any need other than the comfort of the family trying to provide care for her. And so she was our initial entry into the community paramedicine program. And just for a little background, our community, not only does it have home health, but it also has the unique advantage of having a district nurse. And so there was sort of a overabundance of home health providers. So we were trying to figure out where we could kind of fit our program in and not step on anybody else's territory, and also validate and have some sort of need for us and not have a program sort of searching for some sort of problem to address. And what we found was by partnering with home health and the district nurse that this person in particular needed so many different services that we were able to multiple times a month prevent an admission that would be for no reason other than comfort of the family, to just prevent those, first of all, 911 calls, and then the complication of going in, being admitted to the ED for a while, then having to return them by ambulance back home. Sometimes they might be concerned, the family would be concerned to the point where there would be some ill health effects, and they would result into an admission for a week at a time. So that was probably the by far the biggest example of how we saved taking this patient in repeatedly, kept her at home. The family has kind of established a new comfort level of her care, so they feel like they have some sort of backup and community support. So some of the less scary incidences that this patient has aren't as bad and dramatic as they had been in the past. And on the other spectrum, one of the patients that we have seen recently that is a new entry into the program is a 6-month-old with newly diagnosed reactive airway disease, and the mom not being comfortable with how to use a nebulizer, and us being able to help get her comfortable and familiar and provide some interim assessments until she was able to get up to speed and feel comfortable managing that her infant. So those two probably dramatic cases are, for at least for our service, has really clearly demonstrated the need for community paramedicine, even though there are a lot of resources in particularly our town, and it's demonstrated quite a savings in at least admissions, time, effort, 911 calls. And in the summertime, we're a pretty big tourist community, so our year-round population goes from 7,500 to upwards of 40,000. So when we're having to manage these patients that are calling emergently, particularly this one that I'm using as an example, it really does impact our response pattern, because we'll be several calls deep with a lot of people in the community, and then this would happen, and it would be something that would be fairly minor that, had we been able to be in the home like we are now, would have dramatically cut some of the response pattern adjustments that we'd have to do with mutual aid and whatnot. So the ripple effect of having this program, for at least for our community, is pretty huge.
Yeah. And Scott's been able to go out a number of times when the physician is concerned about the patient and have eyes on the patient, and been able to reassure the physician when the patient wouldn't necessarily want to go to the ED, and give some eyes and ears in the home, which has also been really helpful.
Right.
I also wanted to say, I'm sorry, I forgot, the number, where our referrals have come from. I have numbers for that. So from the ED, we've had 17 visits that have come from the ED. From home health, it's been 309 visits. From the urgent care center, it's been 8 visits. Togus, which is our local Veterans Administration hospital in Augusta, we've had 1. We've had 3 referrals from a surgeon, 275 from the PCP offices, and 17 from the hospital. So it's kind of interesting, because we thought there would be more coming from the discharges from the hospital or the ED, but it really hasn't gone that way yet. So it was something that we learned, and definitely had a different idea when we started the program. So some of the biggest learnings, I think, from this program has been the small community that we have here. And Scott was speaking really to the Boothbay area, where there are a lot of resources. So the other 2 service areas don't actually have the district nurse or that extra level of care that Boothbay has. But even in our county, we just have people that know each other. We have great connections, and we have some great people that have been on the team I think that has been really key to the success of our pilot program. Our home health intake nurse, who actually has recently left the organization, was extremely proactive in getting referrals and making those extra calls to go the extra mile for the patient. She would call. I mean, we've had referrals from Boston for the program, from all sorts of different areas, even many outside of our county, because she was always willing to call the people that were involved in the patient's care and say, hey, did you know about this service? We can get these people into the house to help the patient. So she has been really integral in our pilot program. Scott, did you want to add anything about what we've learned so far?
I think probably the most important thing is the involvement of home health. That without that has been key to the success of this program. We were sort of flailing around looking for momentum, and once we partnered with home health, that's when things really solidified and was our kind of breakout moment. And our partnership with home health, it can't be emphasized enough.
Mm-hmm. And I would say sorry.
I'm sorry, Julie. This is Kevin. While we're on that topic, we did have a question come in about that specifically. They asked, since you have such a close interaction with home health, each community paramedicine pilot has to be licensed as a home health provider, correct? And that actually is not the case in Maine. None of the pilot projects have been required to license as such, and that comes after Attorney General review. I don't know if you have anything to add to that, Julie.
No, I was actually hoping you would address that question because we're not a home health provider, but yeah. No, so I don't have anything to add. Sorry.
Okay. Sorry, go ahead.
What I was going to say was I was involved in other discussions in another area of the state where home health wasn't as on board with starting a program and didn't have that vision to see how beneficial the relationship could be both ways, not just for community paramedicine to benefit, but also I think home health benefits from seeing the patients, for 8 more weeks where home health is being looked at for those readmission rates or the 30-day readmission rates. And being involved in trying to get another program started in another part of the state where home health wasn't on board, it just wasn't able to move forward. So I think it is really important to partner, and I think I'm trying to figure out a way where we can show how we've helped home health with their readmission rate. And this is only one of a few projects that I help with up here, so I haven't been able to really look into the data. But I know we've been able to keep people out of the hospital and help people with our anecdotal stories. But I'm hopeful that we'll be able to show it through some hard data as well as the program continues to grow. And so where are we now? So we're 2 years into the program, and now I think what I'm looking at and what we talked about as a group last week is who are we targeting? In looking at our application, we had said we were going to target specific diseases and look at frequent utilizers, and I think that there's still a lot of opportunities there. One thing, we have a new medical director, we have a new primary care medical director, and looking at are we targeting CHF, COPD, or even cellulitis, which was one thing Scott brought up in the meeting, and are there more opportunities to be a little bit more targeted with who we're helping? Should we pick 10 to 15 patients who we know are frequently going to the ED or frequently going to the hospital and have a more set program where we see them for a number of weeks to try to work with the primary care physician a little bit more closely and the patient to give them some more education in the home. So looking at that, and we have had some staff changes, so just making sure that the program continues in the way that we have had it. I'm actually leaving as well, so making sure that we can just continue the momentum and keep the program going because I think it has been just a really great program. So that's all I had prepared. Scott, did you want to add anything else?
No, I think you've covered just about everything that I can think of, unless there are questions.
Well, that's great, Julie and Scott. Thank you so much for being with us today. I would just add that we've had probably the greatest success at this point in Maine in two programs that have formed close relationships with home health, both here and then over in the Lewis and Auburn area in more western Maine. And that actually the example set by Lincoln County is now moving to a couple of neighboring counties that are going to be incorporating a service also embedded in the home health network. So clearly, I think you guys have set the pace for what may become a common operating model, at least in the state of Maine, as we move forward. The money that you guys collected through, you mentioned that Boothbay utilized some of that $40,000 for a response vehicle. How about the foundation monies that were used? What kinds of things were you underwriting with those?
We were supporting training, vehicle maintenance with that, and then we were paying $21 per visit, or we are paying $21 per visit for each community paramedicine visit.
And that goes to the service that provides the visit?
Yes, that goes to the service that provides the visit. So the way the grant was written, there was a little bit of time in there for my time, but the way I am paid, we couldn't actually support my position through that grant funding. There's a little bit of money in there for the coordinator at home health as well, or some coordination of the program, but unfortunately they couldn't use my time. But so the services have gotten the majority of the money, with a little, like maybe a couple of thousand that has gone to other things, but not much.
What do you, when that grant money runs out, is that going to cause problems for the services?
Well, and Scott, you can speak to this as well. What we were hoping with the grant was that by the time the grant ran out, that there would be another payer in the mix. So hopefully the Maine Care or Medicaid program would be supporting community paramedicine by that time. So we were kind of using it as the interim, with the hopes that there would be another payment option for the program when the funds ran out.
For our grant, sorry.
Go ahead. Go ahead.
All right, Susie, sorry. For our grant, we have a foundation in our community that funds unique and innovative healthcare programs, and it's one-time funding. They don't want to do ongoing funding for projects. So we use, and at the same time that this project came to us, our community hospital was closing. So this was an opportunity to kind of partner in, and for the foundation to use some of sort of what the intention of community paramedicine with some of the in-between time of emergency calls. We also use some of this money to offset some of our payroll expense, because the foundation provided us with some funds not only to buy the response vehicle, but also to use some funds for crew time, which helped us to transition our community from the 2 or 3 people that we had on staff before to the 4 staff person per shift model that we're using now. Moving forward, we're hoping that this will start to take off with Medicaid funds or some sort of reimbursement, but the basic expenses are already part of our budget anyway.
Okay, that's great. And the aspiration for Medicaid funds in Maine is not just an idle hope.
Right.
Scott and Julie and I and a number of folks in Maine have been meeting with our Medicaid program called Maine Care for the last year and a half, and we feel that we're getting very close to actually having some reimbursement, having the state Medicaid plan changed, and having some reimbursement that way. So there really is some hope for that. Are there any other questions out in the audience?
The conference has been unmuted.
So all the lines are now open. So if anybody has a question, speak up. Well, it looks like you may be off the hook, guys. Do you have any last words of wisdom for us?
No, if anybody has questions or anything they want answered not on the call, people are welcome to email me or email Kevin to get to me about any questions or that they might have. I'm happy to answer anything.
That would be great, and I would echo that. You have all received the notices from me, my email. It's McGinnis, McGinnis @nsunso.org. Please feel free to send any questions you may have, and I will see that either Julie or Scott gets them.
Thank you.
Yeah, thank you for letting us present to you guys. I really appreciate it.
Yeah.
Well, it was an absolute pleasure to have you, and appreciate this unique model being something that our audience could take a look at and consider. Our next edition for March will be on the 21st of March at 3 p.m. Eastern Time, and we will have a notice coming out on that soon. The archive recording of this program will be up within a couple of days, and we'll send out a note when it's available. I know there are a lot of folks out there taking President's Day off, and will want to look at this later on. So with that, I want to thank Julie Carroll and Scott Lash. I want to thank Gary Wingrove for his continued help and partnership in this program. And we'll talk to you in March.
Thank you.